The topic of this lecture is Physical Uncertainties in Light Ion Beam Planning and Delivery. The objectives for this presentation are to provide a survey of the sources of physical uncertainties in light ion beam teletherapy planning and delivery, give the audience a feel for the magnitudes of the uncertainties and how they influence light ion beam treatments, and provide some examples of mitigations for some of the uncertainties.
Major references for this lecture are my book entitled Practical Implementation of Light Ion Beam Treatments and a report from task group number 202 of the AAPM entitled Physical Uncertainties in the Planning and Delivery of Light Ion Beam Treatments. Not all uncertainties will be addressed in this introductory presentation. Please consult the references for more comprehensive information. Although many uncertainties will be provided in this presentation, these are meant to be only representative examples and may not match those at any particular facility. Each facility must determine the uncertainties appropriate for the equipment and procedures used at the facility. Each facility must determine what level of uncertainty should be accommodated. For example, 1.5 sigma, 2 sigma, or 3 sigma. Each facility must also follow their own perceptions of risk. There are several types of uncertainties pertaining to the planning and delivery of ion beams, including identification of targets in normal tissues, biological effects, dose compliance, lateral alignment uncertainties or LAU, penetration uncertainties due to physical characterization or PUPC, penetration uncertainties due to beam delivery or PUBD, and penetration uncertainties due to lateral alignment. This lecture will concentrate on physical uncertainties, so the first two will only briefly be mentioned.
Uncertainties in identification and segmentation of targets in normal tissues come from clinical examinations, image quality, contrast or metabolic agent specificity, and physician training and experience. Two references concerning identification of targets and contours are listed below.
The main biological uncertainties considered in treatment planning are due to the relative biological effect, or RBE, being dependent upon the ion species and depth, the type of tissue, the dose fractionation schedule used, and the response of each individual patient. The magnitude of biological uncertainties is usually larger than physical uncertainties, but the effect is generally smaller. For instance, they do not cause geometrical misses. Uncertainties associated with dose compliance include items such as reference dose per monitor unit calibration, field uniformity, spot size and shape, and flux stability. Due to the limited time today, I'll not discuss these items. Please consult Section 3 of the AAPM Task Group number 202 report for details.
Let us spend some time to provide some examples of lateral alignment uncertainties. Examples of these uncertainties include targeting, planning, alignment, and delivery. These are similar to those found in megavoltage X-ray and electron teletherapy, but some differences do exist because of the increased size and weight of the devices for light ions and the closer proximity of devices to the patient to reduce scatter.
Some major targeting uncertainties include the accuracy of X-ray computed tomography image reconstruction and the contouring model. The contouring model can be affected by the number of points per contour in each plane, the number of contouring planes, contouring in perpendicular and oblique planes, and interpolation between contours. In the picture at the right, contours were only drawn in transverse slices, but in a coronal slice, one contour is seen to jut out significantly into the brain. One could question if this is real. Depending upon the answer, one could treat extranormal brain tissue or risk missing part of the target. There are many uncertainties associated with the planning of a treatment, a few of which are listed here. The first is the location of the isocenter relative to the image set. The second is the accuracy of the aperture design or spot scan pattern that places the field edge. This can be dependent upon the margining method and, for an aperture, the number of points in the projected aperture contour. The third is the accuracy of digitally reconstructed radiographs that are critical for aligning the patient with the treatment portal. Lastly, the accuracy of both the lateral and distal penumbra dose models can affect the applied margins and doses delivered to target and normal tissues. For modulated scanning beams, the predefined positions of the aiming spot grid versus the target can produce a less than optimal treatment. In the figure at the right, each circle represents an aiming spot and the thick black curve represents the projection of the target. Spots within the target and within a small distance outside of the target are selected for use. Depending upon where the spot grid intersects the target, some aiming points, shown by blue cross S's, must be selected for use that are further away from the target edge. This causes a dose to increase outside the target, resulting in a non-conformal treatment. Contour scanning, where the spot position follows contours along the target edges, might do a better job at creating a conformal dose distribution at the lateral edge of the target, but this method of scanning has seldom been used. Perhaps uncertainties in delivering the beam and aligning the patient with the beam are the most visible, but they are also difficult to quantify. Most lateral alignment uncertainties in light ion beam treatments are similar to those encountered in X-ray and electron beam treatments. However, the magnitude of some may be larger and there are a few extra. This diagram illustrates some of the sources of uncertainty during beam delivery. The blue frame represents 1/8 of the structure of a rotating gantry. Attached to the gantry is the radiation head. A translatable applicator carriage is used to mount an applicator that holds beam shaping devices such as apertures and boluses as close as possible to the patient to minimize scatter and improve conformality and dose accuracy. Some systems, such as those that use the modulated scanning delivery technique, may not use an aperture but may incorporate a multi-leaf spot trimming collimator. During delivery of a treatment, the beam enters the radiation head of the gantry from the right, probably through a bending magnet. Both the position and the focus of the beam can be uncertain. The beam might next pass through a segmented ionization chamber that is used for monitoring and centering the beam. The position of this ion chamber has some uncertainty. Next in this beam line is an X-ray tube used for localization and aligning the patient with the beam. This tube slides into and out of the beam path and its position is uncertain. The beam then passes through the radiation head, applicator carriage, and applicator that are all susceptible to the effects of gravity. The radiation head can sag, the applicator carriage that moves back and forth can become skewed, and the applicator can be mounted to the applicator carriage slightly different each time and can also sag. The aperture in a bolus may not be installed perfectly inside the applicator cone, thus projecting to a different part of the patient than planned. On the opposite side of the patient is an X-ray detector plate for taking localization images. This device may not be exactly aligned with the treatment beam. After localization images are taken, there are uncertainties in the position of the positioner after executing the prescribed moves, such as between the setup position and the treatment position. Finally, even though motion mitigation techniques may be applied, there's always a residual motion of the patient, both translational and rotational. This slide shows measurements of the mechanical isocenter of a rotating proton gantry. The diameter of the isocenter for this gantry was about 1 millimeter, but some gantries have a larger size, some almost 4 millimeters. Some systems can compensate for the increased diameter of the isocenter using software adjustments of the patient positioner, but the uncertainties of these systems need to be carefully studied. This table gives, for example, head and neck and abdominal cases, the estimated uncertainties at the 2 standard deviation level of the component uncertainties from each of the 4 categories mentioned before: targeting in pink, planning in yellow, alignment in white, and delivery in green. The second column identifies the uncertainties as being type A, think random, or type B, think systematic. It is highly unlikely, however, that all the systematic items will tend to the same direction. Therefore, the total uncertainty from all components was calculated by summing them together quadratically. Some uncertainties can, however, be correlated, such as gravity exerting a force on the aperture that is inserted into the applicator, that is mounted onto the applicator carriage, that is attached to the radiation head, that is attached to the gantry. This quadrature method of summation therefore underestimates the total uncertainty, and the total values listed in the bottom row represent a lower limit to the margins that would need to be applied to assure target coverage and normal tissue avoidance. In practice, typical applied lateral margins are 3 millimeters for head and neck treatments utilizing face masks and 5 millimeters for abdominal treatments, but each facility should investigate the uncertainties appropriate for their equipment and procedures.
Let us now move on to some examples of penetration uncertainties due to physical characterization of the patient or devices. Major uncertainties include the accuracy of XCT numbers, accuracy of stopping powers, and conversion of XCT numbers to stopping power. Arguably, the largest physical uncertainty that affects the penetration of light ion beams is the accuracy of X-ray computed tomography numbers. It is known that the XCT number for a given material is a function of scanning parameters, patient shape and size, position in the reconstruction volume, and artifacts. The image on the right shows that the XCT value is not constant even within a box of water due to artifacts in the construction of the image. The graphs at the bottom left, taken from Toth in 2012, show how a single energy XCT number changes as a function of patient diameter and kVp for different materials. These dependencies may decrease in the future with the adoption of spectral XCT scanning. To make an accurate treatment plan for light ion beams, it is important to use a standardized and commissioned scanning protocol. A patient is never just one diameter, and thus there is not one XCT number that is correct for designing portals and calculating dose distributions. Since one value is not correct at all places within a patient, an uncertainty is associated with the number assigned to each voxel. Scaling the numbers to air and water is one method to improve the accuracy for individual patients. An equation used at the Massachusetts General Hospital more than 30 years ago forces the values of air and water for each patient to be the standard 0 and 1000 values. A screenshot of a data entry box from a treatment planning system shows typical scaling values for air and water for a head patient. The value of water may be obtained from the CSF fluid in the ventricles of the brain, the vitreous humor in the eye, urine in the bladder, water in a rectal immobilization balloon, or an external container filled with water. If none of these water-like materials are present in the image, muscle or brain may be used by applying the known ratio of the XCTNs of muscle or brain to water for input as an unscaled value of water. There are many artifacts and XCT scans used for ion beam planning. This slide shows some common XCT artifacts. The image at the upper left shows some beam hardening artifacts produced by the skull. The image at the lower left shows some artifacts not found in axial scanning, but produced in helical scanning at the edges of high-density objects. Generally, these two types of artifacts are localized and do not cause widespread penetration differences. If investigations show that they could result in penetration differences, the planner should contour these regions and override the stopping powers or the XCT numbers, depending upon the treatment planning system requirements. The image on the right shows artifacts within a long flat tabletop that would affect the penetration of a beam entering the patient from underneath. The penetration of a beam into a patient is also affected by the uncertainties and stopping powers. If one uses analytical or Monte Carlo calculations in their planning system instead of measured data, then the absolute values of stopping powers are important. Currently, the absolute linear stopping power of water for protons is only known to about plus or minus 1%, and there is disagreement between different tabulations. As an example, the range tables given by Janney and ICRU 49, both of which were determined by integrating energy loss calculated from stopping powers, differ by almost 4 millimeters for 250 MeV protons. A number of studies over the years have shown that the I value used to calculate the stopping power of water is closer to the value of 82 electron volts used by Janney than the 75 electron volts used in ICRU 49. The ICRU has since recommended changing the value to 78 electron volts, but the uncertainty remains. The values of relative linear stopping powers or RLSTPs, are more commonly considered than the absolute stopping powers because most treatment planning systems still use dose calculation algorithms based upon measurements in water. The uncertainty of the relative linear stopping power values for materials through which therapeutic beams pass range from 0.4 to 3.3%, with most tissues being less than 1.6%. In the high-energy proton range, the energy dependence of the relative linear stopping power is less than 1.5% for tissues and less than 8.5% for high atomic number materials. In the low-energy proton range, however, the dependence may be as great as 5.6% for soft tissues and up to 35% for high atomic number materials, even though most planning systems ignore this dependency. The Monte Carlo method of dose simulation should be more accurate than pencil beam methods with respect to this aspect.
In addition to the uncertainties associated with the XCT numbers and the relative linear stopping powers, there are also uncertainties associated with the functions for converting the XCT numbers to relative linear stopping powers. In some TPS implementations, this conversion is a two-step process, and in some TPSs, it's a one-step process. In the two-step implementation, the first step links the XCT number to a material definition. This link is primarily dependent upon the spectrum of the CT scanner X-ray beam and is therefore dependent upon the design of the scanner and the scanning parameters. The second step involves assigning a relative linear stopping power to the defined material. This assignment is a physical constant and independent of the scanner used. Most TPS implementations combine these two steps into one that links the XCT number directly to the relative linear stopping power. This graph shows several sets of measurements, calculations, and models for using the one-step process. In addition to proton values, the graph also has values measured for carbon and iron beams, demonstrating that the difference between ion species is small. Experiments at several institutions have suggested that, for standard tissues, this function is probably good to within 1.6%, but a set of measurements performed with a single phantom at multiple institutions, which I'll show next, suggests that the uncertainty might be larger. For materials other than tissue, such as mobilization equipment, catheters, and other implants, larger deviations can occur as shown by the blue squares. Additional uncertainty allowances should be applied to plans when these materials are present. This slide shows the same graph but magnified to better show the region containing most soft tissues. It is obvious that most phantom materials do not accurately simulate real tissues. Uncertainties can arise because of the sparsity of accurate real tissue data, the models used to predict the values for real tissues, and because different tissues may have the same scaled kilovoltage X-ray CT number, but a different relative linear stopping power. A simple method for obtaining a tissue conversion function has previously been described and uses a phantom containing water and a small diameter aluminum plug. The aluminum plug essentially allows a measurement of the average X-ray energy of the scanner that can then be used to construct the conversion function. This phantom was taken to all 10 operating proton facilities in the USA during 2010 and 2011 and used to measure 14 standard tissue conversion functions and compare them with the functions independently obtained by the facilities. This graph shows the differences in derived relative linear stopping power between the facilities and the standard. For tissues within plus or minus 300 XCTN of the value for water, all facility functions produced converted RLSP values within plus or minus 6% of the values produced by the standard function and within 8% of the values from any other facility's function. For XCTNs corresponding to lung tissue, converted RLSP values differed by as great as plus or minus 8% from the standard and up to 16% from the values of other facilities. For XCTNs corresponding to low density immobilization foam, the maximum to minimum values differed by as much as 40%. If a beam traverses a large thickness of these materials, the beam penetration may be in error. This study indicates that the uncertainty in converting XCT numbers to relative linear stopping powers may be, by itself, around plus or minus 2.9% at the 2 standard deviation level. This study did not indicate which facility had the best function, but some facilities may have errors exceeding the uncertainty values they apply in the planning process.
Sometimes XCT images contain pixel regions which cannot be converted accurately to relative linear stopping power, or to which the pixel values may change from day to day. This can happen for registration and immobilization devices, gas bubbles, contrast agents, metal implants, and artifacts. Tissue motion and anatomical variations between imaging and treatment configurations are also common. For such cases, the planner may draw structure contours and manually assign better estimates of the relative linear stopping powers to those regions. The image at the upper left shows maroon-colored contours drawn around the teeth for assigning teeth fillings. The image on the upper right shows an orange-colored contour for assigning high XCT number artifacts. The image on the lower left shows a cyan color contour for assigning low CT number artifacts. The image on the lower right shows the image after all assignments have been made. Note that on this TPS used to generate these pictures, the relative linear stopping power values above the maximum value in the conversion curve, in this case above 2.57, appeared black. After substituting relative linear stopping power values, the planner should increase the penetration uncertainty for physical characterization value unless the relative linear stopping power is known exactly, such as in the case for a tabletop.
This table summarizes some penetration uncertainties due to physical characterization of the materials in the planning XCT images for typical cases. Some of the uncertainties can be mitigated using various procedures such as given in the third column. The fourth column gives example assumed uncertainty values after the mitigations are applied. For patients without metal implants, severe artifacts, or other oddities, these uncertainties can be added in quadrature to give a value of plus or minus 4.3% at the 2 standard deviation level. Currently, most facilities are using a value of only 3 to 3.5% for normal conditions. In the future, the use of Monte Carlo calculations and the introduction of dual energy X-ray CT or ion beam CT may decrease the PUPC value to as low as 2.2%. Let us now move on to some examples of penetration uncertainties due to beam delivery. Major uncertainties include the accuracy of the beam energy, accuracy of beamline device water equivalent thickness, accuracy of bolus construction, and accuracy of alignment device water equivalent thickness and alignment. Typically, the absolute accuracy of the penetration is only required when measuring the depth dose distribution for use in planning treatments or if planning using Monte Carlo or analytic-based techniques. Usually the concern is instead on the reproducibility of the penetration to ensure the planned penetration matches the delivered penetration. This reproducibility affects adequate tumor coverage, distal blocking of normal tissues, and patch portal combinations. The relative accuracy is also important, such as when the energy stacking technique is used for range modulation. For instance, a uniform mesa produced with a proton beam from a synchrotron requires a relative accuracy of 0.1 MeV at 70 MeV and 0.2 MeV at 250 MeV. In other words, near an energy of 70 MeV, a planned 2.3 MeV jump in energies must actually be between 2.2 and 2.4 MeV to give a uniform dose throughout the mesa. The calculated dose distribution shown in this slide was part of a study to determine the accuracy required for a modulated scanning and energy stacking beam delivery system. In the study, several variables were randomly adjusted to determine the effects on the dose distribution. Some of these variables included finite scanning speed, intensity monitor response time, beam spill non-uniformity, energy errors, spot position errors, noise on intensity monitor electronics, injected flux control, selection of average beam flux level, and flux fluctuations during delivery. This graph plots the root mean squared dose error when random errors up to 0.2 MeV in energy and up to 2 millimeters in spot position were used with two different spot spacings and either single pass or multiple pass rescanning. The results show a substantial dose error when these errors are present. For single pass scanning, 3 to 8% errors were found. Overlapping points by using a smaller spot spacing and multiple pass rescanning reduced the error, but reducing the energy and spot position errors could also help. Historically, reducing the uncertainty associated with measuring the absolute beam range has been limited by the equipment used. This table lists some of the component uncertainties associated with scanning an ionization chamber in a typical commercial water phantom. Achieving an absolute range better than plus or minus 1 millimeter at the 2 standard deviation level is difficult without having specially designed and built equipment. The repeatability of the range, on the other hand, can easily be determined for an ion beam to 1/10 of a millimeter. Measuring the energy of accelerated ions within a synchrotron is fairly straightforward. This slide shows how several beam position monitors and a frequency counter placed around the accelerating ring can be used to measure the velocity, and thus the energy, of ions before a beam is sent to a patient. What is more difficult is ensuring that the thickness of materials in the radiation head has not changed from day to day. To reduce the uncertainty of the energy of the ions that are accelerated in the ring, the tolerance of a beam energy interlock may be configured. The diagram on the left gives an example of how the interlocks can be set for a synchrotron. The vertical direction represents the delivered energy with the line in the middle of the green area representing the prescribed energy. Around this value is a green region denoting the energies that are allowed to be delivered to the patient. The yellow areas represent the energies for which delivery is aborted for the current extraction cycle, but for which the accelerator is allowed to automatically adjust and try again on the next cycle. The red regions represent those energies in which the treatment delivery is terminated and a notice is sent to the human operator for corrective action. The picture on the right is just a screenshot of a user interface display of a beam energy monitor indicating that the current cycle was within the deliverable region. At Loma Linda in 2003, this tolerance region was set to plus or minus 1/10 of an MeV. This small tolerance is necessary to enable accurate stacking of energies. Please note that the energy tolerance is not the same as the uncertainty of the energy. The interlock may or may not truncate the standard delivery distribution. Although the energy extracted from the accelerator may be correct as prescribed, uncertainties in variable thickness beamline devices, such as range shifters or scatterers, accidental damage of the thickness of radiation head components such as radiation detectors, vacuum windows, and ripple filters, and accidental changes in the delivery of planning system configurations may lead to wrong penetration in the patient. To increase the probability of detecting accidents and reduce the probability of mistreating patients, beam range measurements at the patient position must be made daily. This plot shows the results of measurements over a 9-month test period showing that, even with variable thickness component parts, with proper design in QA, the maximum range deviations from a synchrotron can be limited to less than about plus or minus 0.1 millimeter. Data from cyclotron facilities in USA typically showed a larger day-to-day deviation. Many ion beam treatment facilities use a bolus to reduce the dose to normal tissues distal to the target. There are several uncertainties associated with the bolus water equivalent thickness. With proper lot sampling, the physical density may be controlled to within plus or minus 0.5%. Errors due to voids and or contamination of a bolus can be limited to less than plus or minus 0.5 millimeters if proper QA is performed, including CT sampling of each lot. Continuing quality assurance of milling machines and portal-specific inspection of each bolus can probably minimize manufacturing errors to plus or minus 0.3 millimeters. Alignment devices are another source of penetration uncertainty. When a face mask is used, it is unlikely that the holes in net precisely align over the same anatomy as when the XCT scan and plan were performed. The net part of a face mask is typically 1 millimeter thick. Tabletops and pods are often made of materials such as polycarbonate, polyvinyl chloride, or fiber composites that do not lie on the tissue XCT number to relative linear stopping power conversion curve. Multiplying the thickness of these devices by the error in the conversion can often lead to a systematic penetration error of 1 millimeter. This slide summarizes some example penetration uncertainties due to beam delivery. The first column lists some of the expected uncertainty items, with the other 4 columns giving example uncertainty values for beams produced with different techniques. The total value that is typically applied in treatment planning for penetration uncertainties due to beam delivery is 2 to 3 millimeters.
After estimates of the PUPC and PUBD for a given plan are available, the important ion beam planning concept of range modulation expansion needs to be applied. The graph in this slide shows a depth dose distribution for 90% to 90% mesa width of about 12 centimeters. If there is an uncertainty that either the XCT numbers, the XCT number to stopping power conversion, or, for Monte Carlo, the XCT number to mass density conversion, were too low by 5%, then the plan should be optimized to stop the beam at a 5% greater depth. The red horizontal axis assumes the tissue is 5% more dense than the XCT numbers indicate. In this case, the distal 90% dose should be set to a depth of 32.5 centimeters instead of 31 centimeters. If the uncertainty went the other way and the values were too high by 5%, then the plan should be optimized to stop the beam at a 5% lesser depth. The blue horizontal axis assumes the tissue is 5% less dense than the XCT indicates. In this case, the proximal 90% dose should be set to a depth of 18 centimeters instead of 19 centimeters. To accommodate both scenarios, the mesa width should be the difference between the maximum distal depth and the minimum proximal depth, in this case 14.5 centimeters with uncertainties instead of 12 centimeters without uncertainties. The expansion needs to account for both the PUPC and PUBD uncertainties. Note that the range modulation width along each ray line from the source through the target will be different at each off-axis location.
There are some uncertainties that have no specific numerical values, and the effects can vary tremendously depending upon the treatment situation. These uncertainties must be mitigated by planning procedures. Some of these situations include the lateral alignment effect on penetration, straggling through heterogeneities, and patient motion. Previously, we discussed some consequences of bolus manufacturing. A different kind of uncertainty associated with the bolus is the alignment of the anatomy with respect to the bolus. The simulated plan on the left of this slide shows a target in red with a critical normal structure in green. The plan on the right shows the dose distribution that is delivered when the bolus is misaligned with the patient by 3 millimeters. This can occur because of incorrect placement of the bolus in the applicator, incorrect DRRs, faulty localization, isocenter sag, or many other problems. In this case, the upper side of the target is underdosed and the organ at the lower side of the target is overdosed. The exact same situation can occur with a modulated scanning beam if the patient is misaligned with respect to the scan pattern.
Two methods that are used to mitigate the effect of alignment on penetration are bolus or scan pattern expansion and range modulation extension. This slide shows a simple example of an irregularly shaped target, shown in red, in a homogeneous patient. A bolus, shown in blue, is used to control the maximum penetration of the beam into the patient at different locations off-axis. If the patient were to be aligned upward with respect to the beam, the range modulation width along ray A must be extended to adequately cover the thicker target. Of course, when the patient is in the nominal position, the modulation width will appear too large. If the patient were to be aligned downward with respect to the beam, the bolus must be extended or thinned along ray B. In addition, the range modulation width must be extended to cover the target when the patient is aligned in the nominal position and the thin bolus is used. This technique can work to mitigate the effects of both lateral alignment uncertainties and patient motion.
Another issue that must be dealt with in planning is straggling through heterogeneities. This illustration shows how ions traversing equal water equivalent depths can scatter and stop along a measurement line at different depths. Ions enter the muscle phantom from the top of the figure. Red lines represent paths of 3 separate ions. The thick black vertical line represents a line along which dose measurements are made. The ions that pass through the high-density light blue bone material on the right and scattered to the measurement line stopped at a shallower depth than the ion that passed through the muscle. The ion that passed through the low-density yellow lung material on the left and scattered to the measurement line stopped deeper than the ion that passed through the muscle. The stopping of the ions is not coherent, and a depth dose distribution measured along the black line near the end of the range would thus have a shallower dose gradient with depth near the distal edge of a target than if the phantom had been made entirely of muscle. As the degree of heterogeneity increases, the distal slope of the depth dose distribution measured along the line becomes shallower. Urey and al. Have studied this effect. The dotted curve in each graph represents a standard depth dose distribution measured in water. The solid curves represent depth dose distribution measured along 3 different lines passing through a head phantom, one line being superior and one line inferior to the arrow. Each line has a varying degree of heterogeneity around it. The change in the depth dose distribution is obvious.
One method of reducing the impact of heterogeneities, straggling, and potential lateral alignment uncertainties is to split the incident portal into 3 portals at slightly different entry angles. In this way, localized regions of underdose and overdose are moved around, lessening the effect. Typically, only one beam entry angle is chosen each fraction, but different angles are used for different fractions. This slide lists several treatment techniques for periodic intrafractional anatomical variations. These include, but are not limited to, breath hold, beam gating, beam tracking, random rescanning, rescanning with synchronized delay, and apneic oxygenation. Regardless of what technique is used during treatment, there will still be residual motion of the anatomy. The planner must therefore apply a secondary planning technique, such as using the maximum intensity projection XCT images, assignment of relative linear stopping powers to voxels, target expansion, or bolus expansion.
This slide summarizes some of the typical penetration uncertainties. The penetration uncertainties due to physical characterization, such as the CT number, relative linear stopping power, CT number to relative linear stopping power, and relative stopping power assignments total to between 3 and 5%. The penetration uncertainties due to beam delivery, such as the energy or range, depth dose modeling, bolus design and manufacture, and alignment devices, total to between 2 and 3 millimeters. Other items such as beam and patient alignment, heterogeneity straggling, and patient motion can be mitigated through planning procedures such as bolus expansion, modulation extension, and use of multiple angles.
In summary, 6 remarks can be made concerning physical uncertainties in light ion beam treatments. Lateral alignment uncertainties are similar to those found in megavoltage X-ray and electron treatments, but may include more components and differ in magnitudes. The penetration of a light ion beam in a patient is uncertain due to several factors associated with the physical characterization of the radiation objects and the beam delivery. The quality of lateral alignment can influence the penetration of ions relative to the tissues. Patient motion can influence the penetration of ions relative to the tissues. Straggling through heterogeneities can alter the depth dose distribution. Treatment planning procedures may be used to mitigate uncertainties at the cost of either treating more normal tissues and/or reducing the probability of covering the target.